call this meeting to order. Welcome to meeting number 127 of the House of Commons Standing Committee on Health. Before we begin, I would like to ask all in-person participants to read the guidelines written on the cards on the table. These measures are in place to help prevent audio and feedback incidents and to protect the health and safety of all participants, including the interpreters. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108, Sub 2, and the motion adopted on November 8th, 2023, the committee is resuming its study of the opioid epidemic and toxic drug crisis in Canada. I'd like to welcome our panel of witnesses. We have with us today, appearing as an individual, Dr. Patricia Conrad, clinical psychologist and professor of psychiatry and addiction at le Centre Hospitalier Universitaire Sainte-Justine, Université de Montréal. Elle est ici par vidéoconférence.
She's here by video conference.
Judson also appearing virtually, and Gregory Sword, who was with us in the room. Representing the Canadian Mental Health Association, Margaret Eaton, National Chief Executive Officer, online, and Sarah Cannell, National Director, Public Policy. Thank you all for taking the time to be with us today. You will have up to 5 minutes for an opening statement, and we're going to begin with Dr. Conrad. Dr. Conrad, welcome to the committee. You have the floor.
Thank you very much for inviting me to speak to you today. I have, as a expert in the field of drug and alcohol prevention, I want to raise a number of concerns. As you know,
Excusez-moi, Monsieur le Président, excusez-moi.
Apologies, Mr. Chair, and apologies to the witnesses.
Est-ce que je pourrais...
I would like to respectfully ask to our interpreters to speak directly into their microphones. As you may know, the volume in this room is quite low, and my earpiece is at 85%, and I can't quite hear the interpreter. So I would like to ask them to speak directly into the microphone, if possible. Thank you.
See, Mr. Thériault, I presume you heard that, Dr. Conrad. So,
Chair.
Ms. Kayabaga, please.
I would also request that we up the volume. I can't hear what she's saying.
Okay.
Yeah, thanks.
All right. Ms. Goodrich.
Yes.
Just a second, Dr. Conrad. Okay. If you could just say a couple of sentences, we need to tweak the sound level so that everyone in the room can hear. I'm going to have you restart your statement once we get all this figured out. Go ahead, Dr. Conrad.
Just say a few words without going ahead. Is that it? Can everyone hear me okay? I'll wait for you to give me the word to start again.
Is the volume in the room okay now? Can everyone hear me all right? Welcome to meeting number 127 of the House of Commons Standing Committee on Health. Does that sound okay in your earpieces, folks? Okay, Ms. Kayabaga?
I can hear you fine. I can't hear her sound.
Okay.
Yeah.
Why don't you try that, Dr. Conrad?
Are you able to hear me now? I'm speaking up. I can try to speak louder.
Okay. Is it okay in the earpieces? Okay. Please restart. Sorry for the hiccup. Sometimes that happens. Go ahead, right from the top,
problem.
Dr. Conrad. Thank you.
Right. Thank you for having me speak to the committee today and for your focus on this concerning health crisis, the opioid overdose crisis, which is affecting young people. I've submitted a statement late last night that I hope you all read in relation to how the opioid crisis is affecting young people. More young people have died from opioid-related deaths than alcohol-related deaths, despite the much higher prevalence of alcohol use amongst young people in Canada. The Ontario OSTIS study recently reported that compared to all other drugs, opioid use is increasing amongst young people, and now over 20% of high school students are reporting having tried an opioid in the past year. There are a number of solutions to addressing addiction. They don't just involve acute treatment and pharmacological interventions. They also involve indicated prevention programs, universal prevention programs, and selective or targeted prevention programs. And that's what I want to speak to you today about. In my brief, I have highlighted a number of systematic reviews, one that was reported by the Surgeon General in 2016 in the US, that provides a very thorough overview of the evidence-based prevention programs that are currently available and can provide solutions to the current opioid crisis in Canada. There's also a report by United Nations Office of Drugs and Crime, as well as a joint report by WHO, UNESCO, and UNODC. In all three of these reports, there are programs that have been developed in Canada and tested in Canada, but they are not being widely distributed and made available to young people in this country right now. I chaired a committee, a working group focused on the emerging health crisis to find solutions for at-risk and young users of opioids. We reported a systematic review that was published in the Canadian Journal of Psychiatry a few years ago. And in this report, we identified only two programs that have been shown to prevent the uptake of prescription drug misuse amongst young people. One is the PROSPER delivery system that has been widely evaluated in the United States. The second is the Personality Targeted Prevention Program, which was developed in Canada and widely tested in Canada. In relation to a significant evidence gap with respect to solutions for young people who are using opioids and at very high risk of overdose deaths or transitioning to a lifelong experiences of addiction and dependence, we conducted a number of focus groups with at-risk users across the country. And a number of recommendations are reported, and I refer you to a number of publications that were published in the Canadian Journal of Addiction Medicine. And the overwhelming message that came from these qualitative interviews with at-risk users was the need for more youth-oriented programs and the desire for more school-based programs, workshops, face-to-face interactions, discussions related to risk for prescription drug misuse, including addressing underlying mental health challenges, peer pressures, and concerns about other people's use. I'd be very happy to go over the evidence in relation to prevention programs that are currently available in Canada and that could be widely implemented. I just want to finish with a number of recommendations to the committee on how we could better address young people's risk for opioid overdoses in this country. First, communities need help reviewing and making sense of a very complex literature on drug and alcohol prevention. I recommend that Health Canada maintain a review process and a registry for evidence-based drug and alcohol prevention programs, similar to what has been made available through SAMHSA in the United States and other state registries for evidence-based prevention programs. We need more federal funding for drug prevention in this country. As you know, alcohol and drug misuse represent enormous costs to society, but less than 1% of those costs are dedicated to prevention, to implementing prevention programs in the country. Communities need additional resources to help them in adapting evidence-based programs and evaluating their implementation in new contexts where there are evidence gaps. And in light of the growing health threat to young people brought about by the opioid crisis in North America, Health Canada should explore ways, or the Canadian government should explore ways to incentivize provinces and territories in setting statutory orders and minimum standards for drug prevention so that every child in the country is exposed to an evidence-based program immediately. We need a more coordinated implementation, resource, and evaluation tool. This could be easily attached to CIHR's CRISM network, but we need more resources dedicated to research and evaluation of prevention and not just a focus on opioid substitution therapy treatments, which has been mostly what the research has been focused on to date. Health Canada should also stop investing in drug prevention strategies for which there is limited scientific evidence. And I can talk more about that. And finally, we need better online safety for children and young people. The illicit drug market has transitioned to social media, and that is where kids are being groomed for lifelong substance use and misuse. And it's extremely important that we begin to look at new ways of protecting young people online. Thank you.
Thank you, Dr. Conrad. Next, Dr. Martin Judson. Welcome to the committee, Dr. Judson. You have the floor.
Thank you, Chairman. Thank you for this invitation to speak before the House of Commons Standing Committee on Health. I, Martin Judson, am a physician licensed to practice in the province of Ontario, which I have done for 49 years. Initially, I engaged in general practice and then specialized full-time in addiction medicine, commencing in 1990. I'm certified by the International Society of Addiction Medicine and in the management of substance misuse by the Royal College of General Practitioners, UK. I was the first physician to prescribe methadone for the management of opioid dependence, which is the same as addiction, west of Toronto, and that was in 1991. I co-authored the first edition of methadone treatment guidelines published by the College of Physicians and Surgeons of Ontario. Subsequently, I became the medical director of Clinic 528, which at one time retained 22 physicians managing the disorder of opioid dependence for over 1,400 patients. In the mid-1990s, methadone prescribing was closely regulated by Health Canada and the CPSO, otherwise referred to as the college, in order to minimize mismanagement of patients, drug diversion, and overdoses. The protocols necessary to achieve these goals were followed strictly, and patient safety and improved health were noted. Initially, the Clinic 528 operation met significant resistance from local businesses, but after anxieties were allayed, the clinic became a respected part of the community. Anecdotal information from the London Police Department indicated that petty crime decreased. Since the introduction of what is called safe supply clinics in London, the number of patients enrolled at Clinic 528 started to decrease, and many of the patients who have remained have continued to exhibit instability in their recovery from the disease of addiction. I accept that opioid replacement therapy in the form of methadone and Suboxone does not meet every patient need, and alternative opiate prescribing is acceptable, necessary, and indicated. But this should involve long-acting opioids. The use of short-acting opioid preparations, such as Dilaudid, which are not monitored nor regulated, significantly increase the risk for patient destabilization, overdoses, diversion, homelessness, and crime. The political situation in London has not helped mitigate these risks. Both Health Canada and the College of Physicians and Surgeons of Ontario have seemingly abdicated all responsibility for oversight, resulting in many physicians and pharmacists engaging in the practice of prescribing short-acting opioids which aggravate addiction. It is important to recognize that those who suffer with addiction can be considered to be suffering with a disease. The use of opioids is also choice, a means of coping, and a reflection of decay in society. The remedy is not to prescribe abundant amounts of opioids, but instead introduce controls and support systems which will help not just patients, but also prescribers, dispensers, and the local communities. Once patient stability is established, health, responsiveness, pride, and integrity can develop. Safe supply, for the most part, does not induce such progress. Thank you.
Thank you, Dr. Judson. Next, Mr. Gregory Sword. Mr. Sword, welcome to the committee. You have 5 minutes for your opening statement. Go ahead, sir.
Thank you for having me. I lost my daughter 2 years ago to this opioid crisis. I fought for the last 2 years to save her life, and I failed. The ease that she was able to get Safe Supply was just one click on Snapchat, and she would be able to get any drug she wanted within 5 minutes. She was in and out of the hospital for the last 2 years of her life. Her first incident of an overdose was on fentanyl. The mental health was called in to give her a report, and within 5 minutes, she was released from the hospital, saying that she was okay. For my daughter, she was suffering from ADHD. When we did lockdown for COVID, it took her out of her regular routine, and she had no escape. She wasn't used to being confined for the entire day, so she started to go more and more online. At that point, she started to dabble. She first started off with marijuana, which then went to bars, which was the street Xanax. And then finally, she was introduced to dillies. Me being a naive father, she would talk about going out for a dilly bar. To me, that's ice cream, so it never raised any concern to me. She would hang out at Dairy Queen with all of our other friends. It progressed from there into the point where she had another overdose, almost a year to the day before she died. We had 1 year to save her, and we failed. Every time a youth counselor would come in, they'd give me the same thing. She has to ask verbally for help. My daughter was stubborn. She would never ask anyone for help. Me being a father, I had to sit there and watch my daughter commit suicide for a year without able to help her. We would have drug counselors who would come in to talk to her, and they would tell her that marijuana is okay for her to continue to use. It took me right out of the picture. I could not control any substance my daughter took. In her mind, that gave her the right to keep on smoking marijuana, which put me in the hardest position of my life. Do I let her go to the streets to get her marijuana, or do I become a drug dealer to my own daughter? I took the latter and started to give my daughter the marijuana she needed to make sure that she was getting a safe amount. But that wasn't good enough for her. She liked the pills. And the ease that she was able to get the pills was unbelievable. She would go to the local park, and she would have what they call Safe Supply within 5 minutes. And she was embarrassed of doing it. Her and her friends, after the second overdose, decided that they needed to stop, but they would not ask for professional help. She got to the point where she was embarrassed, and she is an addict, so she started to hide it. She would wait till I went to sleep, then she would take her pill in her bed. I would be gone to work the next morning, so I would never see the effect of it until I got that fateful phone call that she was found dead in her bedroom. Since then, I've reached out and tried to figure out what went wrong. I've talked to MLAs, I've talked to the police. The police keep on telling me that they're handcuffed. Talking to counselors, they don't have enough resources. My daughter's best friend, after she died, has overdosed 2 more times. Her other best friend has overdosed 3 more times since her death. We finally got one of them into rehab. After she finally reached out and asked for help, It took her a month and a half to find a bed. For a teenager, a month and a half is a lifetime, especially when they're struggling with addiction. We could have lost that girl very quickly because we do not have the funding to help these children overcome their addictions. That's everything I got to say right now.
Thank you, Mr. Sword. Next, the Canadian Mental Health Association. Ms. Eaton, will you be taking the lead?
Yes, I will. Thank
Okay,
you so much.
The floor is yours. Thank you.
Thank you so much, and good afternoon. Thank you for this invitation to appear before the committee to support this timely study. And I very much want to thank Greg Sword for his powerful words and for the courage that I know it took for him to come and share his story. And I offer my condolences to him and the families across this country who have lost loved ones because of this toxic crisis. The Canadian Mental Health Association delivers free, frontline, community mental health, substance use health services in more than 330 communities across every province and the Yukon, in rural, northern, and urban settings. Community mental health and addictions care is a critical complement to physician and hospital-based care. Our services can range from mental health literacy and integrated youth hubs, case management and navigation, clinical counseling, addiction withdrawal management and treatment, stabilization units, supportive housing and mobile crisis teams and helplines, including participating in the National 988 Suicide Distress Line. However, it is a constant struggle to meet the growing needs of Canadians, with long waiting lists for services across the country. Frontline community health organizations sit outside the primary care system, a reality that is baked into the 40-year-old Canada Health Act, which only guarantees access for those struggling with mental health and addiction issues to emergency rooms, psychiatrists, and family doctors, and not to the essential mental health and substance use health care provided by community organizations. This means most community-based mental health and substance use health services are not covered under provincial and territorial health insurance plans. As a result, we are underfunded and left to piece together short-term project funding and fundraising off the goodwill of Canadians who have the capacity to give. Further, community health organizations are often left out of crucial healthcare conversations with decision makers. There are also severe wage inequities for our staff compared to hospitals and other healthcare centers. This, coupled with the long waiting lists, leads to high levels of burnout, low retention, and high turnover. Our workforce is exhausted and grappling with moral distress, trying to respond with compassion and energy to a crisis that is worsening. I've heard from frontline staff about the challenges they're facing in response to the toxic drug crisis. Across the country, they tell us about how their clients are ready to be in treatment, but they sit on a wait list for 4 months because there are no publicly funded treatment options available. They tell me about their clients who are in recovery, but they relapse because they don't have housing, let alone housing with wraparound supports. They tell me about the pain of losing multiple clients to opioid poisonings in just 1 week. I believe that everyone in this room shares a common vision to ensure our communities are safe places where our families and friends can thrive. A vision that ensures that there are supports for those who are struggling with mental illnesses and substance use disorders so that they can get the help they need when they need it. Of course, we want to respect jurisdictional areas of responsibility, but there are specific programs, policies, and legislation which you as federal decision makers have the power to act on. So here are 3. Number 1, most importantly, amend the Canada Health Act to explicitly include community-based mental health addictions and substance use healthcare services. Number 2, earmark funding under the National Housing Strategy, specifically for transitional and supportive housing units. A person can receive the best possible addictions treatment, but if they don't have a place to call home, then we are neglecting a foundation to their recovery. And number 3, task Health Canada with coordinating a federal plan to address the crisis. Our system can't rely on jails and hospitals. Our communities deserve better. Federal leadership is needed to coordinate a compassionate and integrated approach. The opportunity of this study is to bring mental health and addictions healthcare on par with physical healthcare. I urge you as federal legislators to act. I'm joined by my colleague Sarah Kennel, National Director of Public Policy, who is in the room with you today, and she is there to answer any questions that you might have. Thank you so much for this time.
Thank you, Ms. Eaton. Okay, that concludes our opening statements. We're now going to begin with rounds of questions, starting with the Conservatives. Ms. Goodridge for 6 minutes, please.
Thank you, Mr. Chair, and I want to thank all the witnesses for their testimony, and specifically to Gregory Sword for sharing about your daughter's circumstance. I really appreciate that. I'm going to start my questions to Dr. Judson. In your opening statement, you stated that both Health Canada and the College of Physicians and Surgeons of Ontario have seemingly abdicated all responsibility for oversight. I was wondering if you could expand on that.
First started prescribing methadone, I had to get approval from Health Canada. I had to have a special exemption to be able to prescribe methadone. It was contingent on having taken a course in the prescribing of methadone, which outlined its neurochemistry and the effect on the pharmacokinetics of methadone. I had to meet such special requirements before the College of Physicians and Surgeons that I was in good standing to be able to prescribe opioids. And so those two authorities, the College and Health Canada, effectively screened me out as being someone who was going to be prescribing methadone for legitimate reasons, and the likelihood of over-prescribing, inappropriate prescribing was minimal. That seems to be not the case, just because the number of patients who are experiencing opioid misuse renders it far too difficult for them, for physicians. There are so many physicians treating that patient population that it's really impossible to keep controls over things. It would just consume far too much time. I presume. I can't say more than that.
Thank you. Could you, in your professional opinion, share what is the correlation between the availability of substances and the harms they cause?
Well, if you think not just of opioids, but recognize that all substance misuse is the problem. It doesn't matter what you use. It's the fact that an individual uses a substance that really defines what addiction is. And as long ago as the early 70s, soon after I opened up in practice, was impressed by a research paper that had been published by a sociologist at the University of Western Ontario. His conclusion was that the more available alcohol is, the more alcohol is consumed. The more alcohol than is consumed, the more problems occur as a result. And that has recently been corroborated by a study conducted actually in Ontario, but published in the journal entitled Addiction, which is published in the UK, which looked at opioid use. And the conclusions were that the more opioids that are prescribed, the more opioids become available to all people for legitimate and illicit reasons, and the more problems occur as a result, including increased health issues and increased visits to emergency rooms. So those two reports, spanning a 50-year history space, indicate that the more substances are available, the more problems there are going to be. And that's what we're witnessing as a result of these safe supply clinics, which are giving an abundant amount of opioids onto the street. And if they were better regulated, these clinics, then that would probably rein in the amount of opioids that are finding their way onto the streets.
Thank you. Dr. Conrad, I see you shaking your head, and could you perhaps expand and share your thoughts on that subject as well?
My understanding of the literature is very similar, so I concur with all of those comments. And it also puts people at risk. So the more substance use and in the adult population, the greater risk for a youth population, the more the liberal attitudes about substance use, the more young people are likely to use and at younger ages. There's even studies demonstrating that proximity to alcohol outlets, for example, will influence young people's rates of substance use, alcohol use, for example. And I'll reiterate how concerned I am about the fact that opioid use amongst young people is rising. And what that means is that Canada will continue to have a very significant problem for decades to come.
I appreciate that. Greg, so how easy was it for your daughter to get access to these potent Dilaudid pills?
One message on either Snapchat or Instagram, and she would have someone delivering her whatever she wanted within 5 minutes. She could get dillies, cocaine, acid, alcohol, whatever she wanted. Even after she died, they were still messaging her cell phone. My friend had access to her Snapchat account, and they were still asking if she'd need any dillies.
Camilla's friends have said that dillies were widely available at their school. Can you expand on this? It terrifies me as a parent that high potent opioids are available in schools.
Most of the kids there would get the supply from someone who would go into the Vancouver East side, and they would be able to pick up a bunch of pills and bring them back into the smaller communities where I lived. And before my daughter died, there was 2 other girls in the same area who had died of the same thing with no mention of it. I only found out from other parents. It is so easy for these kids to get their hands on it because we don't monitor it in BC. We just hand out the pills, hope that the addicts will take them and not sell them for the drugs that they want. So they give them to the kids or to the gangs, and they come back out to the smaller communities.
Thank you, Mr. Sword. Madame Brière for 6 minutes, please.
Merci for being with us. Je vais adresser mes questions en français.
I will be asking my questions in French to Dr. Conrad. In your opening remarks, you talked about different solutions, not necessarily pharmaceutical ones, but prevention, universal prevention programs that would be more targeted. I believe that your research pertains to how to strengthen, or rather on what can push someone to use and what these prevention measures could look like. And if you could talk to us about prevention measures that you are currently working on. Certainly. Do you mind if I respond in English?
Yep. So thank you very much. You've clearly done your research, and I appreciate that. So absolutely, there are a number of evidence-based prevention programs that should be widely available to all young people. There are only 3,400 high schools in the country. That's not an enormous task. They are under-resourced and do require dedicated resources in order to support these programs, because they are not just a poster in a hallway or a lecture by someone who has had an experience with substance use. These are psychological interventions or multi-year programs that involve building skills in families and in young people that help them manage stress, confidently resist peer pressure to use. So giving young people tools on how to say no really does work. Counteracting some of the social norms that come from social media, and my research has demonstrated that social media is promoting problematic substance use norms, as well as norms that come from other media and families and society generally. But then I want to talk to you about prescription drug misuse, because prescription drug misuse appears to be particularly linked to risk for other mental disorders. And what we now know from decades of research on psychopathology and neurodevelopment is that there are a number of risk factors for early onset mental health problems. And there are psychological traits that are very good markers of who is likely to develop difficulties with anxiety, depression, impulsivity, and ADHD, as Mr. Sorg described, and other thrill-seeking behaviors. And though young people can report on those traits very easily, and how they report on individual differences such as impulsivity and thrill-seeking will predict who is likely to misuse a substance, what substance they are most likely to misuse, what prescription substance they're most likely to misuse, and what kind of mental health difficulties they're likely to experience in relation to their substance use. And my work has demonstrated over and over again, and these are large randomized trials that have been conducted in the UK, in Australia, and in Canada, and in Europe, involving thousands of young people, that you can deliver cognitive behavioral mental health interventions early on, 7th, 8th, and 9th grade. And when they're delivered in high fidelity by a trained mental health professional, you can delay the onset of substance use in young people. You can prevent young people from developing a substance use disorder. And I believe we haven't yet demonstrated this scientifically. That is how you're going to begin to start to address this problem and reduce the burden on the acute substance use and mental health services. You have to help young people delay the onset of use and stop new users from taking up opioid use, which is what is happening right now and increasing every year for the past almost 10 years.
Que vous avez développé Preventure.
You developed Preventure. Yes.
Est-ce que vous voulez que
Would you like me to talk about that program?
The Preventure program, and I have to say, is one program that I was involved in developing, but there are other researchers, for example, Dr. Sherry Stewart at Dalhousie University, who has collaborated with me in this. And this is a program that has just been packaged to be able to train school-based mental health and educational professionals on how to effectively deliver cognitive behavioral interventions preventatively. And so this program has been demonstrated to be effective when it's disseminated broadly in a community. In about a month's time, there will be a large publication that will come out of the American Journal of Psychiatry demonstrating a randomized controlled trial in Montreal, involving 31 high schools in Montreal, in which there is a very significant effect on substance use outcomes over a 5-year period. Other trials in Australia have also demonstrated that the Preventure program is effective in reducing substance use over 7 years of a young person's life trajectory. So the program has been very widely tested. It's mentioned as an evidence-based program in the Surgeon General's report that was published in 2016. So I have a lot of experience doing this work in schools in Canada and around the world. Through that experience, I do see that schools have become more and more burdened. They're less well-resourced to do the work. And as my colleague said, they are overwhelmed. Rates of just staff turnover and burnout are very high. Social media, addressing bullying, and this need for testing in schools has overwhelmed psychological resources in schools right now. So that's why my recommendation was it's absolutely necessary that we add to the available resources in schools across the country, 1 or 2 health professionals or prevention professionals across the country in every school would dramatically improve young people's lives and reduce the risk for further addiction and overdoses, in my opinion.
Thank you, Dr. Conrad. Thank you, Madame Brière. Suite, Monsieur Thériault, pour 6 minutes, s'il vous plaît.
Mr. Thériault, you have 6 minutes. Thank you, Mr. Chair. Mr. Sword, I would like to start by offering you my sincere condolences. Your testimony was very touching. Dr. Judson, I would like to thank you for your devotion to this matter of substance abuse. Working on this for 49 years is not nothing. The current drug crisis is complex. No doubt more complex than when you could prescribe methadone to somebody who was addicted to heroin, because these drugs are made up of different substances. Experts have told us that in a detox process, one would start with synthetic drugs, and then it is seen that the individual becomes very sick because there's not the means to detox that person from a certain molecule. And if you could talk about the current crisis and tell us what the additional challenges are now compared to when you started working on this.
I apologize. We've got a question because I cannot speak French that well.
Il n'y a pas de problème, vous pouvez parler anglais.
There's no problem. You can answer in English. We have interpreters here. Go ahead. Are you saying that you were not able to understand the question? Because if that's the case, Mr. Chair, we need to show the witness how to use interpretation services.
Dr. Judson, were you able to avail of the simultaneous translation?
No, I did not hear any of it.
Okay. So on your screen, you should see there that you have the option between hearing the proceedings in English, French, or the language that's being spoken. So you must have yours on floor. Can you adjust it to hear everything in English, please?
Where do I adjust that? Sorry, I don't.
It should be on the bottom of your screen.
I just have audio, video, participants, raise hand.
After raise hand, you should see interpretation. Do you see that? On the bottom of your screen.
No, I do. Oh, raise interpretation. I do now. Thank you.
Okay.
English.
So if you press that and then enable English.
I didn't see. Pressed English, yes.
Okay. Et maintenant, dans...
And now, can you hear the interpreter speaking? They should be speaking in English currently.
Monsieur Thériault, s'il vous plaît.
Monsieur Thériault, please ask your question again. Thank you, Mr. Chair. I'll go straight to the heart of my question. I was singing your praises, Dr. Judson. I was saying that your devotion to the subject is remarkable, and you've been working on this for decades. I was saying that at the beginning, treating somebody who was addicted to heroin was easier than the current drug crisis. I would ask you to speak about the difference. Experts have told us that when you start the detox process, you can see that an individual becomes sick because there's not only opioids, but other kinds of molecules that are interacting with the substances, and so this leads to new challenges. What is your experience with this, and what do you believe, or what do you think about the current complex crisis that we're dealing with? You work in an institution, but Mathias Bovin died by taking a single pill, and so this leads to a complex issue, correct?
Correct. And thank you for your compliments. You're correct in saying that it's easier to treat someone with a heroin addiction compared to perhaps using readily available Dilaudid. When we first started treating opioid dependence some 40 years ago, the only available drug was at that time methadone. And methadone is a long-acting opioid agonist, which was first developed for the treatment of pain at the end of the Second World War. And the first methadone clinic was established in Vancouver in the very early 70s. And at that time, Dr. Cassidy noted that patients who were prescribed methadone for the treatment of their pain were quite comfortable and remained on that current dose for a long period of time and never required increasing doses. On the other hand, shorter-acting opioids such as heroin and more certainly Dilaudid, because they are so short-acting, the effect is that you're getting every 2 to 3 hours, the patient is going into withdrawal, and they respond to combat those feelings of withdrawal by taking more opiates. When you take more opiates, you have to understand the neurochemistry of the drugs. And that is that the more, in essence, it's simple for the committee. I can only emphasize that opioids, in actual fact, end up destroying nerve endings. When nerve endings are damaged, then they do not respond to medication. And that's why doses of opioids have to, over time, be increased. It involves those chemicals called cytokines, which some people will have heard of. So when it comes back to treating heroin addicts some 30, 40 years ago, when there weren't any other substances on the street, it was mainly heroin and opium, then the prescription of methadone was very successful, and the numbers of physicians treating gradually grew, and we were able to keep up with the demand. It's really since the introduction of these these safe supply clinics that has led to the overabundance of short-acting opioids, which is naturally destroying the neurochemical integrity of the user, that we've seen the demands that those same patients need ever-increasing doses. So safe supply clinics are in actual fact doing more harm than good. I'm not opposed to alternatives to methadone and buprenorphine, which is Suboxone, which I said in my opening statement, but the alternatives should be long-acting, akin to methadone and Suboxone, and they need to be monitored so we don't get this abundance of short-acting drugs which are diverted, and I've witnessed that myself firsthand. I've seen it on the streets outside my own clinic, and you don't get the abundance of divertible opioids, which end up, unfortunately, in the hands of young people, such as Mr. Sword's daughter. I hope that's answered your question.
Oui, avec des doses qui sont...
With high doses and substances that are a lot stronger than heroin, that's why the situation is so complex. Dr. Conrad, do you believe with mortality rates following a single use when somebody's trying for the first time or for the last time, there's no control on these substances and organized crime? There's no awareness of what's being sold. What do you think about these safe supply clinics, or supervised use clinics and safe supply clinics, do you believe that we need to go beyond saving lives and that we need to work on prevention and treatment? Or do we still need to work on not having people on the streets suffering and dying because we can't control their substance use? Do you agree with safe supply? A short answer, please, because that is all the time that Mr. Thériault has, but we would like to hear your answer.
Briefly, we need a comprehensive drug strategy that includes safe options for people with opioid dependence, but that also includes a much stronger focus on programs and interventions that are going to stop young people from using any drug. So a young intoxicated person is much more likely to try other substances, for example, and what is circulating currently on the streets and on the internet is extremely dangerous for young people. So, the last thing I would say is that it's not just safe supply clinics that have contributed to circulating opioids. It is also day surgeries and the prescription of short-acting pain relief medication for pain management. And that was the beginning of the opioid crisis that then caused people to transition to other more potent forms because they were undertreated, underdiagnosed for their dependence on opioids, and then undertreated. So this has been a 30-year problem that has evolved and morphed into a very complex situation that requires a comprehensive approach to its treatment.
Thank you, Dr. Conrad. Next, Mr. Johns, please, for 6 minutes.
Well, first, thank you to all the witnesses for your important testimony, especially Mr. Swart for your courage for being here and sharing. It's such a difficult issue for everybody here, trying to find solutions, and I want to thank you for sharing so we can talk about them. Dr. Conroy, we heard from Mr. Swart about the fact that his daughter was able to access the internet, and in minutes she could get fentanyl, cocaine, meth, hydromorphone, or marijuana. It was just a click away. You also highlighted that in your speech about the impact of the internet, and you mentioned the need to improve online safety for youth. Can you answer maybe a couple of questions that you could share your thoughts on? What role is social media playing in the youth mental health crisis? And do you have specific recommendations on how we can make the internet safer for youth?
Thank you for this question. I have conducted quite a bit of research on the topic, and the work that I have done has demonstrated that social media, more than other forms of media, is contributing to young people's poor mental health. The work that we have published was attributed to having inspired some of the work that was done by Meta on young people, on the impact of their products on mental health. So there is Canadian research that is informing changing policies in other countries right now around online safety for young people. I really like some of the solutions that have been proposed and passed in the UK and in Europe. And there's even a report that I could make available to everyone on some changes that industry has had to implement in relation to some new regulatory policies in Europe. And they do result in safer practices for young people on social media platforms. So what I can say is that the more a young person uses social media, the more they are likely to experience depression, anxiety symptoms, the more they learn that underage drinking is normal, and the more they're influenced to drink at an earlier age, and we also find the same effect for cannabis. We also have shown that using social media impacts your cognitive development and makes a young person more disinhibited and impulsive, and it contributes to ADHD symptoms. And we know that all three of those behavioral profiles and symptom profiles place a young person at much higher risk for early onset substance misuse. And so social media is directly and indirectly increasing young people's risk for addiction, in my opinion. And it's through access to substances, but it's also through impacting on young people's cognitive development and the development of self-control, as well as influencing their attitudes about substance use. So there are three separate effects. What kind of solutions for Canada with respect to online safety for young people hold industry responsible for the harms? And we're not doing that in Canada, to my understanding. I don't think we should only be focusing on hate speech. There's other harmful effects of social media on young people, and there are solutions to this. So the idea is, I don't know how much time I have, but making sure that products are safer for young people. And we can talk about this perhaps at another time, but holding industry responsible for making their products safer for young people, recognizing that young people are using their products.
Well, thank you so much, Dr. Conrad. We could ask you questions all day. I'm sure it's so important. Youth prevention is, we just don't talk enough about prevention, and so look forward to you sending that information to us. Ms. Eaton, you talked about a recommendation that was made to the committee at a previous meeting was to take a good look at the Canada Health Act because it doesn't cover or support interdisciplinary care for people with chronic complex illnesses. Do you think that the constraints of the Canada Health Act are hampering our response to the mental health and toxic drug crisis that we're facing right now?
Thanks so much for that question. I'm going to turn to Sarah Kennel, who is in the room and is our Canada Health Act expert, to answer that question.
Thank you very much, Mr. Johns, for the question, and good morning, committee members. The fact is that the Canada Health Act only covers services delivered in hospitals and by physicians, which means that services like counseling and psychotherapy, those upstream interventions that Dr. Conrad spoke to, addictions treatment services, all fall out of scope. That means that people who are looking for life-saving addictions treatment services and counseling services that can prevent the worsening of symptoms have to either go without or pay out of pocket, and go without because they simply can't afford that treatment as an option. And that means that the symptoms worsen over time to the point where they are dealing with highly complex issues resulting in criminal activity and repeated hospitalization. Which ultimately costs our system more and is harder to treat. We also see the increasing prevalence of the delivery of addictions treatment services by private providers, which means that there is no accountability, no standards, and no regulatory oversight. And people have to pay tens of thousands of dollars to get into these programs. I've heard of stories where families have to take out second or third mortgages in order to pay for their family members to have access to this treatment. So it's just not considered part of our public universal health system. The solution that is on the table right now is to create an amendment to the Act, which would explicitly include a reference to community delivered, just like the services that Mr. Sword was so sorely looking for his daughter and other community members, which would create an inclusion in provincial and territorial health insurance plans so that people can get the care they need when they need it.
Thank you, Ms. Cannell. Next, Mr. Moore, congratulations on your promotion to the Health Committee. You have the floor.
Thank you, Mr. Chair. And this question is to Dr. Judson. You mentioned in your comments the difference between someone being prescribed a controlled substance and how that medication is closely monitored by their doctor and their pharmacy. Can you explain to those that are watching how this differs from what is now referred to as, I'll say, so-called safe supply that we're seeing in our communities?
Willingly, I'd first like to say that I concur and endorse the comments offered by Dr. Conrod. So we share the same opinions. First off, I would say that it's a misnomer. The very fact that these clinics are called safe supply is an attempt at misinformation, implying that anybody who takes these drugs will be perfectly safe to use them. All they are is just pharmaceutical grade opioid prescriptions. So the recipient knows that the drug has come directly from a pharmaceutical company and it's not been made in a street clandestine laboratory. But the use of such medications is still dangerous, and using the short-acting opioids is just an alternative to patients perhaps using street opioids. But I want to emphasize that the taking of the medication, whether it be methadone or dilaudid prescriptions, is just a small part of for addiction. I always emphasize that when prescribing methadone or Suboxone to a patient, that was an attempt to engage with the patient, establish rapport, and get them steered in the right direction of going to address their psychosocial needs. And the perpetuation of a supply of opioids is in actual fact just perpetuating the addiction. It's not doing anything to change the lifestyle of the individual. That's where most of the raw resources need to go. And if we're spending a lot of time and money prescribing short-acting opioids, we're in actual fact not really affecting any change.
Thank you. Thank you, Doctor. This is kind of ripped out of the headlines, but I want to get your comments on it. Just yesterday, a police raid at a heavily used harm reduction site in Nanaimo resulted in several criminal charges against 2 people. In summary, one individual was charged with 14 counts of possession for the purpose of trafficking and 8 weapons offenses, and another was charged with 6 possession for the purpose of trafficking counts and 5 weapons offenses. Doctor, based on your extensive experience, does that news surprise you?
No, because crime and addiction are somewhat inextricably linked. But I want to emphasize it's not the patients who should be, or the users, those who suffer with substance misuse disorders, they're not the ones who should be targeted. It's the dealers and the suppliers who need to be reined in. And that's why I feel sufficiently strongly that many of the doctors who are prescribing short-acting opioids, I question whether they really understand the harm that they're perpetrating. They're not regulated. If they have inadequate education on the subject, that is just going to contribute to the problem. And I want to emphasize to you that I refer to substance misuse as the 421 condition. Most medical students spend 4 years in their institutions. They, if they are lucky, will get 2 hours of teaching for what is the #1 cause of morbidity. So if you're graduating doctors who really don't understand addiction, you can see how easy it is for them to overprescribe, inappropriately prescribe. And the same applies to pharmacists. They don't have the training and education which is necessary to curb excessive amounts of opioids ending up on the street. And most of those opioids that seemingly are coming from safe supply are ending up in the hands of the traffickers, the accounts of which you just described, because they're accumulating these supplies because that is their business to promote drug use.
Thank you, Mr. Moore. Dr. Hanley, please, for 5 minutes.
Thank you very much, and thank you to all the witnesses, and I will also echo my colleagues in thanking you, in particular, Mr. Sword, for sharing your tragic story of your daughter. And on that theme, I'd like to begin, Ms. Kennel. Perhaps if you could describe: a child is in distress, but not asking for help. Are resources in place? Are interventions in place to assist such a child? And is there, and what would you amplify to enable that child to be able to be helped? And I'll ask you to keep it as concise as possible because I have many questions.
Thank you very much, Mr. Hanley. Thank you very much, Mr. Hanley. My response would be short. The short answer is no. We do not have the necessary supports to help children and youth deal with the mounting mental health and substance use health challenges that they are facing and are going to face as they age. The solution is, to echo Dr. Conrad's points, is building in upstream preventative and mental health promotion interventions that meet them along the way and create effective referral pathways into available community-delivered out-of-hospital treatment options, whether that be early psychosis intervention, prevention programs that deal with addiction and substance use health, to name a few. The issue is that everything is behind a paid door or not available or behind long wait lists.
Thank you. Ms. Kennel, do you consider mental health care a part of primary health care?
100%, and I would gauge that it is core to what medical students learn every day. The challenge, though, is that our health system is not equipped to deliver mental health and substance use health care on par with physical health or primary health. With the shortage of access to family physicians and the lack of adequate and robust training that our medical health care professionals receive, the resulting consequence is that people don't know where to go to get help or face long wait times or inadequate solutions when it comes to addressing their mental health concerns.
Dr. Conrad, I will ask the same question. My first question, the child in distress who is not asking for help. Briefly, if you could comment on that, the availability of interventions.
So the best way to deliver services to that young person who might not be asking for help but is demonstrating signs of struggle is in a school, where the young person has to show up every day until the age of 16, and where it is very easy to provide early upstream psychological interventions to young people, and where there's programs that have been shown to be effective in preventing mental health problems as well as substance use problems. The challenge right now is staffing mental health teams in schools. And there are some advantages to this model, though, in that they can be linked to community-based resources so that when the problem is beyond the capacity of the school, there's a way for a school-based team to interact with health services, for example, and rapidly refer that young people to more intensive care. So,
Dr. Conrad, excuse me, I'm going to interrupt you there. Thank you very much, but I want to give a minute to my colleague, Mr. Morris, to be able to ask a question.
Thank you, Brendan. Appreciate it. The situation in my community in Waterloo Region is dire. Over 63 folks have died from preventable deaths this year. We haven't seen organizations get renewed funding from the Substance Use and Addictions Program as of yet. And we also have a premier who's looking to close safe consumption sites that are saving lives. I guess my question for the CMHA, I really appreciate you've worked with Thresholds to launch an integrated crisis center for mental health in our community. Thank you for that. In your testimony, you talked about having Health Canada launch a new task force for a national strategy to address this crisis. In the time I have left, maybe 30 seconds or so, can you share just a few key points of what you'd want to see in that if we're to listen to the experts and not the partisanship?
Thank you very much, Mr. Morris, for the question. And I just want to really reiterate that the view of the Canadian Mental Health Association is to provide comprehensive wraparound care that spans upstream interventions to help prevent the onset of crisis into more acute services, and then really support people into their path towards recovery. And I would be remiss if I didn't take a moment to really echo support for that wraparound long-term support, which is the social determinants of health. As my colleague Margaret mentioned, unless we have adequate housing, unless we have income supports, we will be facing a revolving door of a crisis. And so our recommendation to Health Canada and the federal government writ large is to develop a comprehensive and integrated plan which scopes out what existing programs are available for community providers like CMHA and others to do that life-saving work on the ground, to fill the gap of what's being provided through the acute care system, and then assess where are there additional gaps. And perhaps it's prevention in school-based prevention programs. Perhaps it is more investments in the social determinants. But we need to take a whole of society, a whole of government view of what the federal jurisdictional responsibility is. And that begins with a plan.
Thank you, Ms. Kennel. Thank you, Mr. Morris. Suite M. Thériault pour 2 minutes et demie, s'il vous plaît.
Ms. Eaton, witnesses have told us, and they're experts in substance use and prevention, they said that 30 to 70% of people with addictions have a mental health issue, and that's significant. And we know about all of the issues with accessing mental health services. What could we focus on in order to treat these people before they self-medicate or before they self-regulate, if I can say it this way? And do you agree with the statement that I made?
I'm going to turn to Sarah Kennel in the room to answer this one. Thank you.
Bonjour, Monsieur Thériault, et merci.
Hello, Mr. Thériault, and thank you for the question.
Millions of Canadians lack access to primary care. And the solution can't be solely hiring more family physicians. If we are going to address the health human resource crisis across the country, we need to look at expanding the health professionals that deliver mental health and substance use health to ensure that we are adequately resourced with social workers, occupational therapists, peer support workers. Those are the types of professionals that we need in order to fund a robust and comprehensive mental health and substance use health system. And sadly, many of those professions are being left out of national conversations regarding health human resourcing, coupled with the fact that those professionals, when hired outside of hospitals or doctors' offices, are not adequately trained or paid for their services. In Ontario, for example, they make 20 to 30% less than their colleagues who are in other health industries, resulting in what my colleague Margaret spoke to, which is high level of retention and recruitment issues and burnout, given the moral distress that they are witnessing on the ground. Our solution is to amend the Canada Health Act with a view to include those services and healthcare providers to ensure that they're adequately compensated and covered within our public universal healthcare system.
Thank you, Ms. Kennel. Next, Mr. Johns, please, for 2.5 minutes.
Thank you, Mr. Chair. I've tried to delay holding off tabling motions to get a first hour from witnesses, but I need to move some motions right now. First motion was put on notice that the committee instruct the chair to write to the Auditor General of Canada to recommend that a performance audit examining the federal government's response to the opioid and toxic drug crisis in Canada, including but not limited to its management of programs identified in the Canadian Drugs and Substances Strategy, be initiated and conducted on a priority basis. I'd like to speak to the motion briefly.
The motion is in order as it relates to the subject matter at hand, so the debate is on the motion.
Okay.
Any debate?
Yes.
Go ahead, Mr. Johns.
Yeah, so I'd like to, hopefully we don't spend a lot of time on this motion. By way of background, in December 2022, I wrote to the Auditor General to recommend an audit be conducted of the government's response to the toxic drug crisis. At the same time, I received a response stating that there was an intention to conduct an audit on the issue, but they did not envision that work beginning in 2023. And now on the website of the Office of the Auditor General, there is a list of anticipated reports for 2024-2025, which still doesn't include any of the toxic drug crisis. So there's now been 15 Auditor General reports on elements of the government's COVID response, with 2 more on the way. I think an audit on the government's response to the toxic drug crisis is overdue, and I hope members of the committee will support this motion. And I just want to mention that on Vancouver Island, only 1 community got SUAP program, 1 riding out of 7. I know my friend from the Greater Waterloo region, Mr. Morris, they didn't get any. So I think it's prevalent that we write to the Auditor General and ask this to be prioritized.
Thank you, Mr. Johns. Dr. Ellis, please.
Thanks very much, Chair. You know, the biggest problem that I would have with this motion, of course, is there's ample opportunity at other times to discuss extending the study on opioids, which to me this directly relates to it. And I think that when we have witnesses here for our friend from the NDP to be needing to bring this forward now is a little ridiculous, when, as I said, there was more than ample opportunity to bring this up at many other occasions. And I'm not sure why this grandstanding is ongoing at the current time.
Mr. Johns?
It's not grandstanding. I'm trying to get this motion moved so that we can write to the Auditor General. And I just put it on notice last week. So this is just timely, trying to get it moving so we can write the Auditor General. I don't think there should be any objection to this.
Any further debate on the motion? Seeing none, are we ready for the question? All those in favor of the motion presented by Mr. Johns, please raise your hand. All those opposed, the motion is adopted. Over to you, Mr. Johns. You still have 2 minutes and 23 seconds.
Okay, Ms. Eaton, you talked about the fact that there's no plan. And
sorry, a point of order, Chair.
Dr. Ellison, a point of order.
I know I just arrived. I apologize, but was he on a 5-minute round? 2.5. Then how could he still have time left? I thought our convention, this committee, was any time you used up to bring forward a motion was actually lost time.
No, the clock stops, and I'm sure Ms. Goodridge would be able to confirm that. Yeah.
It's at the end.
Yeah. Very well. Okay, go ahead, Mr. Johns.
Thank you. Ms. Eaton, you talked earlier, about the fact that there's no plan, and it's something that we've also been calling for. I mean, the government has had a high-level meeting around auto theft, and I'm not saying that that's not an important issue, but they still have not had a summit on the toxic drug crisis. And, they've put forward a plan, but there's no timeline and no resources attached to that timeline. Can you talk and speak a bit about how critical it is that the government put forward a plan with resources and a timeline to implement that, to respond to the toxic drug crisis and the mental health crisis happening in Canada?
Thank you so much, Mr. Johns. Absolutely. We would thoroughly support a summit to address this crisis. The death toll is great across the country, and we can't sit idly by. We will soon be releasing some really interesting information about the fact that provinces have actually reduced the amount of money that they're spending on mental health and substance use care. It is lower than the percentage that they were spending even 10 or 15 years ago. And so we're really interested in the government looking closely at this issue and looking at what legislative means they can use to actually change this situation to save lives. So we would absolutely encourage a plan and a summit.
Do you think that expanding coverage under the Canada Health Act is the best path forward to the challenges we're facing with mental health and substance use care, and what would that solve?
We absolutely believe that a change to the Canada Health Act is necessary. We see provinces not being held accountable for actually investing in mental health and substance use care. We don't have national standards. We don't have the ability of someone to use their provincial health card to go and get the essential services that we need. And we see this patchwork quilt of funding across the country, which means that rural regions are remarkably unserved, even by the existing services of the Canada Health Act, like doctors and psychiatrists, let alone mental health and substance use health services. So we absolutely see the Canada Health Act as a remedy.
Thank you, Mr. Johns. Next, Mr. Steinley, please, for 5 minutes.
Thank you very much. And this is for Dr. Conrad. We've done the so-called safe supply experiment about 9 years now. And I was wondering, before and after, do you have the numbers of overdose deaths before safe supply started for approximately 10 years, and for the 9 years after safe supply has been introduced into the Canadian public by this NDP Liberal government? Has there been numbers, and could you say and extrapolate some information between how many more overdoses we've had in our country before and after this, what they call safe supply, which I don't agree with, experiment?
I'm afraid I can't directly answer your question. I don't know if the data that exists right now could even answer that question. There are a number of different factors that have changed over the past decade and 2 decades that have contributed to the, where we are at right now. I do want to just clarify one thing. So this notion of safe supply is kind of a mixed bag of treatments, services, and possibilities. And I know that there's some researchers from the CRISM network who intend on producing some material that might be helpful to the Canadian government and communities across the country to better just unpack what is meant by safe supply, what practices are safe, and what might actually have unintended consequences for the broader population. So we need a lot more work and clarity around some of these practices.
Yeah, I appreciate that very much. And Mr. Sword, thank you for being here. I had a conversation with a constituent that came into my office, and his son had overdosed as well. And his conversation was very similar, just the ease with which his son, and he overdosed, and this gentleman's grandson was sitting there when his father overdosed, and he was sitting in front of the TV when his grandfather came and found his son dead. And he said the biggest thing he could not do is stop with the ease which his son was getting drugs, and he was getting it online and delivered right to his door. And it's very similar, a Snapchat, but he was accessing the drugs online. And I think Dr. Conrad has done some research on with the ease people can get drugs online now. It's just something that, for me as a father, terrifies me. I have 3 kids, they're 7, 9, and 11, and it terrifies me that with a click of a button, a 12-year-old could get drugs to their doorstep. There has to be you have some data that says, what could we do as legislatures to help that and try and curb with the ease that these kids and adults are getting drugs online?
Is that question directed to me?
Yes, ma'am.
Yes. Yeah. So there's a lot to say here, but it's important that we recognize that young people are using digital media, and therefore digital media must be designed for young people's use, and it's not right now. So there are all kinds of privacy features, for example, and defaults that assume that the user is an adult, when we know that a very large portion of the users of social media and other digital platforms are not, they're minors. And so we can force industry to change some of their default features so that, for example, young people are less likely to be solicited by a stranger online. And that could go a long way to protecting young people. and also monitoring environments where young people meet online.
Thank you very much. And actually, Mr. Sword, I'd like to leave you with the last word. If there's one thing that you could ask us as legislators to do, how do you think we could help to make sure what happened to your beautiful daughter doesn't happen to anyone else? Or the best advice we could have from you, sir?
It's pretty much down to funding. Invest in the mental health of our children. It's our future that we are throwing away. Most kids now are looking at a grim future with the prices, the economy going, and they're not dumb anymore. So they're looking for escapism. So it's either some kids are turning to the drugs to forget about the problems, others are turning to video games. And neither one is mentally healthy for them. So we need to actually invest in our future and get the funding that they need so that they can get the help that they need before they become true addicts.
They need some hope.
Yes. They need a light at the end of the tunnel, and all they see is darkness.
Thank you, Mr. Sword, Mr. Steinley. Next, Ms. Kayabaga for 5 minutes, please.
Thank you, Chair. I would also like to thank our witnesses for being here today, especially Mr. Sword for sharing your heart-wrenching testimony, and my thoughts are with you and your family as you continue to navigate this. Perhaps I would like to start with Mr. Johnson. Mr. Johnson, I'm sure that a lot of things have changed since you started practicing. I'm curious to know if a methadone or Suboxone can be diverted, except maybe injectable formulation is there. Do you think that there's a medication that can be diverted? And do you agree that zero diversions is something that is almost impossible when we're talking about prescribed drugs or even some non-prescribed ones?
There is no such thing as zero diversion. When methadone programs first started in the early 90s, protocols were set in place to minimize that diversion, which required patients who were just recently initiated on methadone to attend the pharmacy every day and consume a witnessed dose of methadone. They weren't able to take any doses of their methadone home until they had achieved evidence of significant stability. And that was usually required over a period of 3 months. After 3 months of a patient denying use of substances substantiated by negative drugs, witnessed drug screens, where the patient would have to produce a sample of urine under witness conditions. If those samples of urine remain negative on a twice-weekly basis over a period of 3 months, then a patient would be able to take 1 dose of methadone home per week. After a month, it increased to 2. So it took 6 months, or 9 months really, to get all your take-home doses, otherwise known as carries. And even that didn't prevent diversion, but it certainly reduced it. Compare that with what is happening in safe supply clinics, particularly in London, is that you yourself could go to a clinic in London, say that you have a problem with opioids. The chances are significant that you would walk out of that doctor's office with a prescription for Dilaudid, enough to last a whole week, and you may have to witness 1 dose in front of the pharmacist, and you get the rest of your doses to take home. If it's not happening immediately, it would happen certainly after about 2 or 3 weeks that you'll be getting maybe 50, 60 tablets to take home, far more than a patient who's just had abdominal surgery would require for the management of their pain. And that is just tantamount to negligence. It's just incomprehensible. It's unconscionable that someone who is active in their disease of addiction is entrusted to take that amount of an opioid home.
Thank you. There hasn't been a lot of conversations around the socioeconomic impacts on people who become patients of drug use disorders. I'm curious to know what perhaps Mrs. Kennel, your thoughts are around some of the comments that the Conservatives have been really pushing on making treatment forced. For example, I'll give just a small example. Some communities have lower income. The median income is much lower than perhaps some of our colleagues' ridings. What are your thoughts on the socioeconomic impacts and these forced treatments? Obviously, we've seen some research that this hasn't worked. And what would happen to people who would be forced into treatments, as treatments are actually sort of offered as jails? What are your thoughts on it?
Thank you very much, Mr. Kirabaga. Sorry. Your question, I would say, has two parts. The first is the socioeconomic context in which people struggling with substance use disorders and mental illness face. And we know, for example, that 25 to 50% of people who are homeless or facing housing insecurity have a mental health or a substance use health concern. The correlation there is unignorable. Therefore, it requires us to be thinking cross-jurisdictionally and cross-sectorally to come up with solutions that truly address the crises and the intersectional nature of the crises that we're facing. The creation of the Canada Disability Benefit coming online this summer is an example of a type of federal intervention that can reduce the strain that poverty has on people dealing with mental health crises and substance use disorders. In regards to the issue of involuntary treatment, I would encourage the committee to focus on interventions that are squarely within the federal jurisdictional purview. We know that every province and territory in Canada has a mental health act. We know that apprehensions under those acts is rising in the face of public threat to public safety and threat to harms at the individual level. Therefore, we know that there are legislative options that are being utilized provincially and territorially. They are not perfect, and we need to acknowledge the incredible amounts of trauma and harm caused when we involuntarily detain individuals that can be long-lasting, while also prioritizing the voices of people with lived and living experience who interact with the system every single day, and ensure that we are responding to their needs and their experiences with the system when developing legislative amendments to those acts or considering new legislative options.
Thank you, Ms. Cannell. Next, Mr. Moore, please, for 5 minutes. Ms. Goodridge, please, for 5 minutes.
Thank you. I'm going to start off my questions. Dr. Judson, we've had people come here from London who are prescribers of the high-potent opioids and actually say that the diversion can sometimes be seen as compassionate. What concerns do you have as someone that lives and works in London, Ontario, when it comes to diversion of these high-potent government-funded opioids?
Diversion must be minimized. That has to be a priority. I'm not opposed to pharmaceutical-grade opioids being prescribed, but is it appropriate prescribing short-acting opioids? No, I've already stated that is counterproductive. Giving take-home doses prematurely when a patient is not stable in their recovery, they've not engaged in their counseling, their psychotherapy, that is not appropriate. Someone who's actively suffering from addiction, for them to be given these short-acting opioids is just something which will deter them from engaging in lifestyle changes. And so that there must be some approach which encourages engagement with the patient and the therapist. And the purpose of the opioid replacement therapy is just to avoid the patient going into withdrawal or suffering from overwhelming cravings. Once those symptoms are eradicated, then the patient is stable. They are more likely to be able to engage in the psychotherapeutic milieu that is provided.
Thank you. To Dr. Conrod, what are your concerns when it relates to youth specifically and the very well-documented diversion that is happening of these government-funded potent opioids that are flooding the streets from coast to coast to coast?
All substances that young people use are diverted in some way. And a small portion of them would have been prescribed directly to them by a psychiatrist or a family physician. And the literature suggests that most young people are actually getting them from friends and family members. So they're not getting them directly from government. They're getting them from, actors in their community. And these people could be better educated. They could be assisted, as Dr. Judson described, in having access to safer supplies of opioids for whatever reason they are being prescribed, either for pain management or for opioid substitution therapies. I do want to just add one more thing to the discussion, and that is what we need to understand is that, yes, mental health is a very big part of addiction. And what we're seeing in the safe supply and opioid substitution clinics across the country is that fewer and fewer resources are available to deliver the mental health and counseling services that Dr. Judson just described. There are fewer funds and people delivering those. And what we know of the evidence for opioid substitution therapies is that they're effective in conjunction with mental health services and counseling.
Do you believe that more needs to be done to prevent opioids and a variety of different substances from being accessed by youth?
I absolutely agree with your statements. More needs to be done on both sides, on the supply side and on the demand side amongst young people.
And so specifically on the demand side, I think that's a great space. And so has your organization been able to access government, federal government funding to help with funding your program of Preventure?
So 3 ways. One, through research, through CIHR. CIHR has rather consistently been through the clinical trials committee supporting research on it. It's been very well reviewed and supported in that way. A lot of work, and it's a long timeline to do research in schools. The second way is through the SUOP program. I've partnered with one group in northwest of Ontario who had a SUOP grant, or was it a PHAC grant, sorry, and they did an implementation in their community of Preventure, and to great success, and it was very well received. And then the third pathway has been through provincial government. So there's a big initiative in Ontario right now through the Health Ministry in Ontario to deliver Preventure across all schools in the province. And so we have reached a point where we've trained over 1,000 community-based and health-based school-based professionals in the delivery of the program. There are a number of challenges to this project, but the objective is to deliver this to 30,000 young people over the next 2 years.
Thank you, Ms. Goodrich. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses. Thank you, Mr. Sword, sharing your pain, your story. My heart goes to Camilla. I know I'm a mother of 2 daughters, and I know how you feel. So, but thanks all the work all the organization are doing on the ground. My question is to Dr. Concord. Dr. Concord, you talked about, the prevention professionals going to be there. We know that youth born after 2010 when social media, technology, screens all around them, we see more and more experts talking about overexposure of technology, as there is a clear link with the impact to mental health. To what degree do you see the impact, to suffer from addiction? What are some other factors in the environment of today's youth impact them? I know there's a question, but what can be immediately the change you're seeing?
The situation is not as unhopeful as we all might think, in the sense that alcohol use and cocaine use amongst young people and tobacco use have consistently declined since the 70s. And so there's quite a lot that we have managed to do around protecting young people from other substances. The one substance that is showing an opposite trend are opioids. So we really need to focus on this particular behavior. Young people's opioid use is increasing despite declining rates of substance use of other forms. And it's an extremely dangerous substance for young people to be using. We need to take this very, very, very seriously. So all the trends are suggesting that there will be many more deaths by young people in this country from opioids.
My next question is to Dr. Eaton. It's good to see you once again, as especially your team in Brampton are doing incredible work on the ground. My first question is to the youth struggling with the addiction, his crisis situation. Recently, we made a distress line equity fund announcement in Peel on expanding the crisis line services provided by CMHA and your partners. Can you provide some numbers to this committee on the number of young committee, on the number of, they are accessing the CMHA distress lines?
Thank you so much. I do not have those numbers at hand, but we would be happy to find that information out and report back. We do know just generally and anecdotally that the numbers are up for youth trying to access services. This is a post-pandemic response. Even though COVID has ended, we know that those youth that develop things like eating disorders, substance use disorders, none of that went away, even though the pandemic stopped. And so I know kids' help phone numbers are up, and usage of 988 has been consistently what was expected across the country. But happy to get back to you with those solid numbers.
Rest of the time, I want to share with Dr. Pawlowski, Mr. Chair.
Dr. Pawlowski, you've got a little over a minute.
Dr. Judson, do you still work at Clinic 528? And I believe that's in London, and I believe it uses OAT therapy, opioid agonist treatment, either methadone or Suboxone. I take it from your testimony, but I wasn't quite sure. You were saying that you think the usage of that clinic and OAT has decreased because of the ready availability of safe supply and safe supply of Dilaudid in London. Do you think that's the case? And is there any evidence that that is the case? Thanks.
Yes, I do still work at Clinic 528, and as I said earlier, we originally had 1,400 patients in 2004. Now we're down to about 600 patients. We used to have 2 or 3 admissions per day. It was Monday through Saturday. That has dropped down to perhaps 1 or 2 per week at the very most. Most of the patients who are wanting sort of treatment for their opioid dependence gravitate to safe supply clinics. Why? Because fewer questions seemingly are asked, less screening, and ready availability of take-home doses before the patients are really become stabilized and got established in a comprehensive recovery program.
Thank you, Dr. Judson and Dr. Pawlowski. Suite M. Thériault pour 2 minutes et demie.
You have 2.5 minutes. Dr. Conrad, you stated that prevention is important. We've seen interventions on the use of tobacco, and there is nicotine addiction now through vaping with products like Zonix, and they have access to a pure nicotine product. And this is quite a significant addiction. What will you do to face that? That's my first question. Second question, can you send us all of the documentation that you've mentioned when you say that we need to work uphill? We understand. But while we do that work, people will die of an overdose because of the poor quality products that are on the streets. And so there is a toxic substance crisis that is causing people to die in the streets. So if you can send all of that to us, that would be great, because I would like to read it. Now moving on to social media that is used to sell drugs to young people, and also that creates a dependency and mental health issues. I'm all ears.
I'm not entirely sure what the exact question is, but I reinforce all of your comments, so I agree with all of them. And so we absolutely need to direct resources to indicated interventions for young people who have started to experiment with substances. We need to reduce their use of substances and absolutely prioritize interventions that are going to help them not transition to more regular use and harmful use of very high-risk substances. We need upstream solutions as well. And we need solutions that will provide people living with substance use disorders and substance dependence with mental health services. They get caught in this revolving door. And I think the committee needs to realize that it's difficult enough to assist someone with a mental health problem. It's also very difficult to assist someone with a substance use disorder. And when you put those two things together, it becomes a very complicated a mix of symptoms that mutually influence each other. And there's this notion called telescoping. It causes difficulties to rapidly accelerate, and it makes it very difficult to intervene. And that is why we advocate for much earlier intervention around the concurrent substance use and mental health problems. And what research has shown from large cohort studies is that there are risk factors that will predict who is likely to experience co-occurring mental health and substance use problems. And we've even identified some of the common underlying factors that will lead to these problems, and that is where the interventions are targeted.
Thank you, Dr. Conrad. Next, Mr. Johns, please, for 2.5 minutes.
Thank you, Mr. Chair. The only time I can table motions is during this committee time, so I hate to do it, but I have to. I'm moving a motion, Mr. Speaker, that pursuant to Standing Order 1082, given the increasing prevalence of privatized healthcare across the country and the difficulty Canadians face in getting the healthcare they need, the committee undertake a study of at least 4 meetings on protecting Canada's public healthcare system against for-profit corporations, and that the committee invite the Chief Executive Officer of for-profit healthcare providers like Loblaws Limited to testify at this committee. And I'd like to speak to the motion if I could.
Okay, the motion was put on notice more than 48 hours ago, so it is therefore in order. I see Dr. Hanley, Dr. Ellis, and Ms. Goodrich. Dr. Hanley, go ahead.
Mr. Chair,
Mr. Johns wanted to speak to the motion. Mr.
Okay,
Johns, you still have the floor, and then you have the floor, Dr. Hanley.
I think it's important. We heard today, about the for-profit healthcare and mental health, straight from CMHA. We need to force the CEOs of these for-profit companies that are literally trying to replace the Canada Medicare system with a cash for care model, and they need to come to Ottawa and explain their plans. And that's what the goal of this motion is that we're seeing doctors and nurses in our hospitals that are being poached by private facilities. And these are doctors and nurses we need also to help with the toxic drug crisis and mental health crisis. But they're also impacting our hospital operating rooms that are sitting empty, emergency rooms are overrun and understaffed. So these for-profit corporations that are already starting to bill people, the message is that families are getting right now is pay up or wait at the back of the line. And I believe that Canadians and certainly the NDP believe in public, universal, free health care. We believe that people and their families deserve the best care no matter how much is in their bank account. And CEOs like Loblaws need to come to tell Canadians why they're working to ruin that. We need some answers.
Thank you, Mr. Johns. Dr. Hanley, please.
Thank you, and recognizing the time and that we still have witnesses, even though a few minutes remain. I think it's an important topic. I want to recognize that there is currently, of course, a contribution from the private sector into our healthcare system today. The Canadian Medical Association has done some excellent recent work on the role of the private sector, including what are the options, as it were, and pros and cons. In that spirit, I propose an amendment, and the amendment enlarges the scope somewhat. I'll read it out. That pursuant to Standing Order 1082, given the increasing prevalence of privatized health care across the country and the difficulty Canadians face in getting the health care they need, the committee undertake a study of at least 4 meetings on the role of the private sector in Canada's public health care system, including the need to protect Canadians against for-profit corporations, and that the committee invite the Chief Executive Officer of for-profit healthcare providers like Loblaw Companies Limited to testify. Thank you.
Okay. Dr. Hanley, I think what you just read was the motion as amended. Can you specify exactly what the amendment or the nature of the amendment is? Because now we have to proceed with debate on the amendment.
Certainly, the addition is the clause, by adding the clause, the role of the private sector in Canada's public health care system, including.
Point of order, Mr. Chair.
Mr. Johns.
And I just accept that as a friendly amendment, and then we can proceed on the main.
No, I don't think you can. We're going to debate the amendment and then the motion as amended. So the debate now is on the amendment. I have Dr. Ellis and Ms. Goodridge.
Thank you very much, Chair. And once again, we see this political grandstanding of the NDP Liberal coalition that has had the opportunity for 9 years on behalf of Canadians to make the healthcare system better. And here we are talking about an absolutely incredible and important initiative. My goodness gracious, colleagues, we have a gentleman here whose daughter died from this opioid scourge, and the two of you want to go on talking about something that you had 9 years to fix. Shame on you. This is absolutely unacceptable and absolutely ridiculous. For Mr. Johns to say that he didn't have another time to bring this forward, in the vernacular, give me a break. That's absolutely untrue. This is foolishness. We have a system falling apart, 7 million Canadians without access to primary care, that both of these individuals who bring forward a motion and an amendment to a motion had the opportunity to address over 9 years and think they have to do it now on behalf of Canadians. This is wrong. In that spirit, Chair, I would move to adjourn debate so we can get back to the important matter at hand that we have.
A motion to adjourn debate is a dilatory motion on which there is no debate. We go straight to a vote. Show of hands, please. All those in favor of adjourning.
I'd request a recorded division, Chair.
We'll have a recorded division as to whether the debate should now be adjourned. Madam Clerk.
Mr. Henley.
No.
Madame Kayabaga. Madame Brière.
No.
Mr. Poloski.
Yes.
Ms. Sidhu.
No.
Mr. Stanley. Mr. Ellis.
Yes.
Mrs. Goodrich. Mr. Moore.
Yes.
Monsieur Thériault.
Oui.
Mr. Jones. Yes, 6, nays 5, 5.
Motion is adopted. The debate on the motion is therefore adjourned. You have 2.5 minutes, Mr. Johns.
I will make sure that it's clear that the Conservatives have many times tabled motions through a really critical testimony on this study, which I believe we should extend as well. So I'm going to go back to Dr. Conroy. Can you talk about what do you think is behind increasing opioid use in youth? Maybe can you explain some of the factors that put youth at risk for substance use harms? And by contrast, what are the factors that reduce risk? Sorry, one more. What can the government do to reduce risks and increase protective factors?
As I outlined in my brief, I think the first thing that needs to happen is that the government support a registry of evidence-based programs, that they help communities review the evidence on what works and what doesn't. It's important to realize that some programs can actually do harm. And so we should only be supporting programs that actually have been demonstrated to, through rigorous research, have been demonstrated to protect young people. We should make those programs available, and then communities that indicate readiness and desire to implement such programs could be supported in doing that. So I've outlined a number of steps that could facilitate the delivery and implementation of evidence-based programs to communities, and that could be done very quickly.
I asked you earlier too about this, and maybe you can give me, do you have an idea, like you stated that Canada is investing in prevention. I think we can all agree around this table. Do you have an estimate of the scale of investment required to implement a universal prevention program across Canada for youth?
I would have to get back to you about that, but it's minimal relative to the costs of substance abuse and the costs of lives lost to the addiction crisis so far. And there's a report by Dr. Jürgen Rehm from 2006, and it's been revised more recently, that suggests that implementing prevention is a very small fraction, like 0.1% of the costs to society by substance misuse. So, for example, I'd have to get back to you on an economic model if you'd needed one, but those can very easily be developed.
Thank you, Mr. Johns. To all of our witnesses, thank you so much for being with us. Mr. Sword, please allow me to add my condolences on the loss of your daughter, and my sincere thanks to you for your courage in coming forward in a public forum like this. It's my hope that the expertise from the other members of the panel and your courage today will all serve to ensure that fewer people have to experience what you have. Is it the will of the committee to adjourn the meeting? Yes, sir. We're adjourned.
Thank you, my fellow panelists.